Well, I think it's getting close. Oh, well, it's actually on the dot. So we should get the webinar up and running. Well, depending on the time zone that you are joining from, morning, good afternoon, and good evening. My name is Jun Kanwoo, Director of the Global Clinical Research Group here in Samsung, Korea. Welcome to the webinar titled Modern Ultrasound in Clinical Practice, the Assessment of Liver Disease. I would like to make an announcement before starting the webinar. Please note that the recording of this webinar is prohibited and intellectual properties of the contents of the webinar belong to the speaker. However, Samsung has granted the rights to record the webinar, and you will be provided a separate link to access the recorded webinar very soon. Please note that the recordings may only be used for education and training purpose only. In order to provide and the audience the best atmosphere to present, listen, and participate, we have set up the default setting of the webinar platform so the video is turned off and the microphone is muted. However, you will have the opportunity to interact with the speakers in the chat box, which is located on the bottom right corner. Please feel free to send in your questions to the webinar, and the will ask the questions to the speakers. Without further delay, let's get the webinar started. We have an exciting of international guest speakers today. Today, I have been given the honor of introducing the moderator and the speaker of today's webinar, Professor Ian. Professor Ian Pereira is the department head of gastroenterology and hepatology at the Victor Babes University of Medicine and Pharmacology of Timisoara in Romania. He has taken part in writing the EPSOM and WOPOM guidelines on clinical use of liver elastography. He has authored more than 300 original papers published in peer-reviewed medical journals and has been a first author of 12 medical books. And most important of all, Professor Pereira is the Congress President of WOPOM 2022, which is going to be held in May in Rome. Please welcome Professor Ian Pereira.
Hello, it's a real pleasure for me to chair this wonderful meeting, and I am very happy because we are here together, hepatologists and radiologists, to share our experience with ultrasound. And the title of this webinar, that it's a very attractive one, Modern Ultrasound in Clinical Practice, looking to the assessment of liver diseases. Then I believe we can have a good afternoon with some important and interesting presentation. And to the end, maybe we will receive enough questions to cover all the points that was not enough covered during the presentation. My co-worker here, my panelists here of high quality, and then I'm very sure that we can have a wonderful afternoon looking to the disease of the liver with our ultrasound, or more specific with modern ultrasound. Then, because I will be the first, I will share my screen to start with my presentation. Okay. Okay. Then my presentation will be about multiparametric ultrasound in patient with fatty liver. Okay, I try to arrange a little my screen. And in our daily activity in the field of hepatology, if some years ago we was focused mainly for chronic hepatitis B or C, in this moment, because we have good treatment for such diseases to control or to heal these diseases, now the hepatologic activity was become more focused on fatty liver. And we call this NAFLD, or non-alcoholic fatty liver diseases. More recent, last year, some paper tried to introduce a new term, and this is MAFLD, or metabolic associated fatty liver diseases. Don't matter the name of the disease, but from this point of view, we will work with the same diseases. And I will start with multiparametric ultrasound. Why we have a multiparametric ultrasound? Because in our hand, in this moment, we have a method, ultrasound, that is give us the possibility to look to the body structure using ultrasound waves. We can use the evaluation of vascularization by Doppler or contrast enhanced ultrasound. We can use contrast enhanced ultrasound for focal liver, and for diffuse, we can make evaluation of liver stiffness, steatosis, or inflammation. And because all these elements are able to be seen by this system, we can say that we have in our hand a multiparametric ultrasound. What we like to have from ultrasound in a patient with diffuse liver disease? Maybe first we like to make evaluation of fibrosis or of the stiffness of the liver, like a prognostic factor. Then we are interested to look to on quantification the steatosis, mainly for patients with fatty liver or alcoholic liver disease. And if it's possible, in the last time, we like to have evaluation of inflammation. And this is mainly for make differentiation between simple steatosis and steatohepatitis. Why we need to have this method, non-invasive method? Because in this moment, the cohort of patients with fatty liver are very, very large one. Then these conditions are mainly in patients with type 2 diabetes and patients with obesity or metabolic syndrome. And this condition is quite frequent in our developed world. On the other hand, we are not able to perform so many liver biopsy for this huge cohort of patients. And then we like to have this non-invasive method to replace liver biopsy. And last one, our ultrasound method for non-invasive assessment, mainly of liver fibrosis, later on of steatosis, and more recent inflammation, are a lot developed in the last 10-15 years. Which are the patients at risk for fatty liver? You can have some image here, and we know this patient. Then something about how often we find fatty liver in the developed world. You can see then it's around 20%, 26% in Europe, but going 31% in Arabic country or 30% in South America. But if you look to the patient with type 2 diabetes mellitus, we have these 55% of them have this condition. But looking in Europe, 60% of our type 2 diabetic patients have this fatty liver. How to make the evaluation, the patient with chronic liver disease using ultrasound? We look for liver stiffness or fibrosis. Then we can use for this biological test, ultrasound-based elastography or MRE. For quantification of steatosis, we can use standard ultrasound-based method or PDFF using MRI. Or more recently, we can use liver inflammation using biological tests, ultrasound-based method, or liver multiscan. I will start with liver fibrosis in affluent patient. Why? Because many studies show the main driver of prognosis of severity of liver disease in this cohort is gained by fibrosis. And you can see here that fibrosis stage, but not inflammation NASH, predict mortality and the time to develop a severe liver diseases. We know in this moment that ultrasound-based elastography can divide it in shear wave elastography and trend elastography. Shear wave elastography is mainly used for the liver and can be divided in transient elastography and point shear wave elastography and 2D shear wave elastography. Something about shear elastography, the probe produces the shear wave without any manual pressure, then without our pressure from our hand. The result is expressed in kilopascal or meter per second or both by a simple button press. And the learning curve is not very long. We need to have maybe 50 or more than 50 examinations to have some experience, but maybe some ultrasound experience is necessary to obtain a good accuracy of our examination. which are the excellent point in liver elastography. Feasibility is very good, more than 90% for all the system. Then we have now many guidelines with recommendation about how to use this ultrasound-based elastography. We have a lot of paper behind showing the results from the literature. And these methods are, cerebral elastography methods are implemented in a new ultrasound machine. And we have some cutoff value, and maybe the most important of these is for advanced fibrosis or cirrhosis that is necessary to be known to start screening for ACC in such patients. I will start with the oldest method, that is transient elastography or fibroscan. This is very simple to be used. In some countries like France, it's manipulated by nurses. It's a semi-blind method because the liver is not seen during the examination. We have three probes, M for normal people, XL for overweight and obese or pediatric probe. On the other hand, the probe must be calibrated periodically, and this means the cost. And more than 1,500 published papers are in the literature in this moment looking to this elastographic method. Everybody knows how look this fibroscan with the both probe here. And about acoustic radiation force impulse technique, these are implemented in ultrasound machine. These are divided in point cerebral elastography, a very simple one, and then 2D, they seem to be more precise from some paper. And you can see here how simple is point is. We find the liver through the ribs, then we put this box here, push the button, and we have the result. The same with other system. We must avoid the capsule and to avoid the vessel inside the liver, and pushing a button, we have the results immediately to know exactly the value. Usually 5-10 measurements are made for this evaluation. Some results from the literature, point cerebral elastography, the VTQ system, it's a meta-analysis with quite 4,000 patients. And our for in comparison with liver biopsy for significant severe fibrosis is 0.84 for significant fibrosis 0.84. For severe fibrosis 3 or more 0.89 and 0.91 for liver cirrhosis, then increasing with the severity of fibrosis. Going to the 2D cerebral elastography, this is color-coded and numeric one. If we look here, we can see we have here a box with a color. This color means no fibrosis here, and we put inside the ROI, region of interest, and inside we have the value of normality. Here it's a color is yellow, and then we have here fibrosis that is in a range of severity, and here is 20 kilopascal, that means liver cirrhosis, and again here a quite normal liver, no fibrosis inside. For some system, or maybe for quite all the system in this moment, we have some qualitative parameter of acquisition. This parallel line show us that we have a good acquisition of the value in the liver. I took here a publication, it's a meta-analysis with 2D cerebral elastography, in which this evaluation was made in comparison with liver biopsy in ACV, HBV, and NAFLD patient. And for significant fibrosis, for all this system, it's more than 85%. And for liver cirrhosis, in all these etiology, the ROX is more than 90. Then very good for our daily practice. For some company, inside the same machine, we can have both point and 2D, that it can be represented and a supplementary point, because we can make a comparison between the value obtained with point or with 2D cerebral elastography. But what is more recent in this field, looking to diffuse liver diseases, we have the quantification of steatosis, and we have the evaluation of the viscosity or viscoinflammation, viscoelastic property like sign of inflammation. For quantification of steatosis, we have not only CAP from fibroscan, but we have attenuation imaging. In FibroScan, we have two value here on the light blue. We have here the value in cap, and here we have in yellow the value of fibrosis. Two information in the same evaluation. The result from control attenuation parameter in comparison liver biopsy, the ROC for cap for quantification of fatty infiltration range somewhere between 0.8 and 0.86. And for NAFLD patient, in a recent paper was proposed some cut-off value in comparison with liver biopsy, and 290, 310, and 330 for mild, moderate, and severe decibel per meter seem to be very simple number that we can keep in our mind. Something about there are different cut-off value for M and XL Pro, because now in practice we use both. And there are two publications that show that we can use the same cut-off value for cap. Don't matter that we have the probe for M or for XL probe. And looking to a meta-analysis about the value of cap, we can see the RO for cap, it's between 0.85 to 0.87 for mild, moderate, and severe steatosis. Again, good results from this meta-analysis. What is more recent in this field? More recent is quantification of steatosis with ultrasound system. Why we like to have this method? We like to have this method because when we perform ultrasound, standard ultrasound, and we find a steatosic liver, we like to have objective evaluation, and we like to have a numeric value. And this can be obtained immediately using this module. And in the same time, next time when the patient comes back, we can give other value, and we can compare the value that was first to the second time. This attenuation imaging, where we can have only this box, and this box, it's a color, an impression color, and we have in the same time here the value of steatosis. It's other system called UGAP, and then we have here these boxes, and we can obtain here many measurements in the same field or in the same image of the liver. And here is the TAI, and this is TSI, both that can have two different modality of evaluation of the steatosis in a patient with NAFLD. Some data from the literature looking to UGAP technology. UGAP means ultrasound guided attenuation parameter, and was made a comparison with CAP and with liver biopsy, 166 chronic liver diseases, and this evaluation was made in the same day, and the ROC for UGAP is from 0.90 to 0.95, and these seem to be better than results obtained by CAP. And this other publication from attenuation imaging, and in this was made a comparison between PDFF and CAP and ATI. And ATI show a good correlation with PDFF MRI method, and this is 0.81, and this is better than correlation with of PDFF with CAP. And when they use the liver histology, they had ROCs that range between 0.84 and 0.93 that are for this method too quite good result for practice. And for Samsung system was made a comparison, and they compare the two system of evaluation, tissue attenuation imaging, and SC from Samsung, and they found then both methods are significantly correlated with MRI PDFF. And for the detection of steatosis 5% or 10%, more than 5 or more than 10, they have very high ROC. They are for AC that it's 0.86 till 0.96. And like conclusion and correlation of this method, MRI PDFF is good for practice. Something now about viscoelastic property, and this is more recent in this field, because like hepatologists, we like to know not only the severity of steatosis, but we like to know if it's inflammation or not. Because if it's no inflammation, we can say that it's simple steatosis. But if we have inflammation in this patient, we have this entity that is called non-alcoholic steatohepatitis, and this is a progressive disease. And then we expect in this patient maybe sometimes to develop more fibrosis. It's a new system that has inside strain point and steatosis quantification, and these have including inflammation. We have a system that is a multiparametric ultrasound, and in which we have elasticity map, propagation map, and a dispersion map. Then we can have information about a lot of facts in the same image. There are two recent papers from the literature in which multiparametric ultrasound was evaluated for liver diseases, and they, in 102 patients with NAFLD, where they perform liver biopsy, they look for this parameter of liver stiffness, attenuation, and inflammation. For steatosis, the AUROC was between 0.93 and 0.83, interestingly decreasing with severity of steatosis. And for inflammation, again, the highest value was obtained of AUROC was 0.89, was obtained when we have a mild inflammation in comparison with severe inflammation. The second paper that was published last year, looking again in 120 patients with liver biopsy and multiparametric ultrasound evaluation for inflammation or for local inflammation, looking to dispersion slope, they obtain 0.89 till 0.85, decreasing with severity of inflammation. For attenuation, steatosis going from 0.88 to 0.79, again decreasing with severity of steatosis, and only increasing for liver steatosis from 0.88 to 0.95, that we know from previous study that the liver stiffness, the accuracy is increasing with severity of steatosis. And the combination of these three parameters give us the capacity to have the diagnosis of NASH with an AUROC of the steatohepatitis of 0.81. That is, from my point of view, for clinical practice, very, very good one. Then some very simple conclusion. In this moment, we have very modern ultrasound system in our daily practice, and this system in chronic liver disease make a multiparametric evaluation in our patient with NAFLD, and giving information about the rate of fibrosis, of steatosis, and inflammation. And with this modern sonographic toolbox for the evaluation of our patient, we try to use to make non-invasive method more and more attractive, trying to replace, when it's possible, liver biopsy. Finally, I invite you for the next year in Timișoara, in this modern convention center, for the World Congress of Ultrasound that will be between 25 and 28 of May. Thank you very much. And now, because you can have the question on chat, then discussion can be done to the end of our presentation. I will go to the second presentation of this afternoon, and it's my real pleasure to introduce Professor Paul Sidhu from King's College Hospital from London. He's a radiologist. He's past president of European Federation of Ultrasound Medicine, and now is honorary treasurer of World Federation of Ultrasound Medicine and Biology, author of many papers, guidelines, and a lot of activity in the field of ultrasound. Paul, please.
Hope you can hear me.
Yes.
Okay,
Yes.
thank you very much for the introduction. I'm going to talk this afternoon on a very more clinical topic and a very new topic of using a technique called microvascular imaging in the liver. Now, microvascular imaging is something that's going to become a lot more popular in the future, and we are looking at many different areas where we can use microvascular imaging as another tool in multiparametric ultrasound imaging of the liver and multiparametric imaging of every organ. So I'm going to take you through a little bit of the technology of using microvascular imaging, and then just show you clinical examples and detail for you the advantages and disadvantages of this technique. Looking at the technology, first of all, I'm going to take you back several years, back to the time where we started to introduce spectral Doppler into our practice. And you have to remember, or some of you weren't even there at the time, but the first spectral Doppler machines combined with B-mode ultrasound had no color Doppler within the spectrum of investigation. And all you would have to do is to move the gate and cursor along the vessel, and in this case it's the carotid artery, looking for the abnormal waveform pattern or the increase in velocity and the higher spectral pattern to make the velocity measurements. Color Doppler came along, and this did transform your imaging of vessels. And in this case, in the carotid artery again, a very thin channel of dissection is easily identified with the color Doppler ultrasound, and placing your gate here to measure the velocity becomes much easier. Power Doppler came along, and this made the interpretation a little better without directional interpretation on the image. And later on, we had contrast-enhanced ultrasound as a Doppler rescue agent. And in this example, again, a very calcified carotid artery, we've got appearances of flow after adding contrast-enhanced ultrasound. But we are now going one step further. We're going to look at an area where you can start seeing vascular flow right down to very small vessel levels. And in this example is in fact a testes, and you can see the normal flow in the testes and the abnormal flow within the tumor itself. So I'm going to just very quickly now show you the technology involved in this. Now, conventional flow looks at vascular flow to a level of quite large vessels, whereas microvascular flow looks right down to the level of microvascular flow with high sensitivity and resolution, and reducing the pulse repetition frequency. Now, you know, by reducing the pulse repetition frequency, you tend to get a lot of artifacts. But this has been worked on and advanced in technology by cutting out all that clutter. Sometimes the clutter is hard to distinguish from the real signals from the vessels, but advanced clutter filters have made this impossible, so that you can now differentiate movement from the tissue from blood flow. It's not completely got rid of, but it's improved greatly over this period of time. So instead of just getting an image with conventional flow where you just see some dots of color flow within the tissue, and again this is in muscle, you're now looking and picking up areas of almost capillary flow within that structure. And this, of course, will have a lot of advantages, looking for particular areas where there's low flow, and the presence or absence of vascular flow is so very important to the diagnosis you make. So let's put that to one side now, and let's look at some examples in the liver. And this is from my experience at King's College Hospital. And remember, it is all in its infancy, and there's no real big studies looking at this or papers telling you whether it's good or not yet. This is just clinical experience. And I'm going to illustrate this with a number of cases that we've seen recently. Now, first of all, this is a 22-year-old female patient presenting with acute appendicitis for an ultrasound, and this was confirmed on the ultrasound examination. As is normal practice, we often look at the liver and the portal vein to make sure that everything is okay and there is no free fluid in the upper abdomen. And an incidental lesion is seen. Adding conventional color Doppler ultrasound to this lesion, and remember, as a 22-year-old patient, this is very likely to be a benign lesion, and on the B-mode ultrasound, this is either going to be probably an adenoma or a focal nodular hyperplasia, FNH. The color Doppler ultrasound gives you that suspicion that there is something going to the center of that lesion. But now look at the MV flow, the microvascular imaging here, and how clearly it depicts that tumor, and it also depicts that vascularity. That vascularity that is not really malignant looking, but more benign looking. So in a few seconds, you've got this image from the patient that gives you a better idea of what's going on. And here it is in real time, and you can see now where there is movement artifact and why even that you can't reduce all the clutter, but you can actually get some idea of what's going on. And compare this now to the contrast enhanced ultrasound examination, where you're seeing that arterial phase only very briefly to see that spoke wheel pattern that you see. But what you get from the contrast enhanced ultrasound here is the hyper enhancement, and there's no washout over time. 25 seconds, 44 seconds, 2 minutes, 37 seconds, there's no washout. Now you've got a new tool which gives you more confidence, and you can examine that arterial pattern within that tumor without relying on that very brief episode with the contrast of that vascularity. And this is a focal nodular hyperplasia. Let's look at another case. Again, it's always incidental lesions you're looking at in the liver, and it's very important to use ultrasound in this sort of situation, because if you've got a patient not coming from the oncology clinic, no underlying chronic liver disease, 90% of these lesions are benign, and you should use your ultrasound examination to confirm this immediately with the patient. But this is a much bigger echogenic lesion. Patient is 27, methotrexate treatment, and there's raised liver function test. Again, there's a pattern of color Doppler flow in there that's not really diagnostic. But what you can see on the microvascular imaging is that this pattern of vascularity is different to the focal nodular hyperplasia that you've seen previously. Remember, she's only 27, no risk factors for malignancy other than methotrexate therapy maybe. And you're looking at now a hepatic adenoma. And if you see and compare your contrast enhanced ultrasound with that, you can see how that vascularity as it came in was very similar to your microvascular imaging. But more importantly, you have to use contrast enhanced ultrasound here because you're looking at the washout. And at 5 minutes and 12 seconds, there is no washout from this lesion. It is a benign lesion. But see how on the previous scan, on the previous examination, how your microvascular imaging gave you that very similar pattern of enhancement to your contrast enhanced ultrasound. And we'll just watch that again, and you can see that pattern of contrast coming in and how it just absolutely looks the same as your microvascular imaging. Here's another lesion. This time it's a 46-year-old female patient, but this time there's a history of breast cancer. And again, there's an incidental lesion in the liver. Color Doppler ultrasound doesn't give you quite that information that you need. And on your MVI, there is no real abnormal vascularity into that lesion. But if you look closely, there is some increased vascularity around the periphery of that lesion. And that should now give you a clue as to what's underlying the lesion. So let's look at this lesion now on the contrast enhanced ultrasound. And the patient has some difficulty holding their breath, and the lesion is moving in and out of view quite vigorously. But just watch the contrast enhanced ultrasound come through on that, comparing that image there. And you're dealing now with a cavernous hemangioma. There's that peripheral globular enhancement, and there's infilling of this complex looking lesion, but it's an atypical hemangioma. And again, the contrast allows you to follow that lesion at 1 minute 12, 2 minutes, 2.5 minutes, nearly 4 minutes, where you're losing that lesion completely as it fills in. So you're dealing with a cavernous hemangioma in this patient. Here's another patient, but this is a pediatric patient with autoimmune hepatitis and chronic liver disease. This patient has a very subtle focal lesion in the liver with not really much of a pattern on your color Doppler ultrasound. The pattern of vascularity with microvascular imaging is very abnormal. There are vessels crossing, but those vessels don't look like they're malignant. They're not attenuated, they're not tortuous. And you can see in another view and another lesion in this patient hanging off the edge of the liver, a similar sort of appearance is seen. And the probability is this is a benign lesion, and you can use your contrast enhanced ultrasound, and this is speeded up a little bit to see that that pattern of enhancement very much mimics what you see with the microvascular imaging. So you're using something that you can see pattern of vascularity in the arterial phase very readily with just your normal ultrasound examination without adding contrast. And this is in fact a regenerative nodule. Here's another patient. This is a patient now with chronic liver disease and a focal lesion. And this lesion in chronic liver disease and in cirrhosis looks very, would alert the physician or the examiner to worry about malignancy. The color Doppler shows nothing very much within that lesion, but if you look at the microvascular imaging and the pattern of those vessels, they are tortuous, they are twisting around, they are attenuated, they are irregular. So this alerts you to the fact that this is very likely to be something that is malignant. It's hyper-enhancing on your contrast enhanced ultrasound, and the delayed phase shows there's washout. So this patient has a hepatocellular carcinoma. But it's interesting to see how your microvascular imaging can pick up the very different vessels within that tumor, looking very much like they're malignant vessels. And this takes me back to the very early days of when we were using contrast enhanced ultrasound in the late 1990s, where we were using this SonoView as a Doppler rescue agent to look at tortuosity and irregularity of blood vessels to determine whether or not the lesion was malignant. Things progressed after that, and we lost that need for Doppler rescue. But this brings back that microvascular imaging gives you the ability now to actually look at attenuating vessels and malignant looking vessels really quite well. Here's another patient. In fact, it's not another patient, it's that same lady with that chronic liver disease and HCC. And she's got a portal vein thrombus, and you can see the portal vein thrombus on the B mode, and you see it much clearer on the microvascular imaging as a filling defect in there. And I'm afraid the contrast image here is a little bit fast. I don't know why that's fast, but there is a filling defect on contrast enhanced ultrasound. You can use the contrast enhanced ultrasound to pick up vascularity within that malignant thrombus. But in this particular case, anyway, there's a very subtle vascularity within the thrombus. So this is a portal vein thrombus, and it's a malignant portal vein thrombus. Let me move on to something else where we've had a look at the use of microvascular imaging, and somewhere where you may not think where you can use it, but movement within the biliary tree. Now, this is a 73-year-old male who's had a hepatococcygeal anastomosis for a bile duct injury when he had a cholecystectomy. I think it was a cholecystectomy performed. And he presents with several years of recurrent cholangitis following this procedure. And I'm going to take you through the investigations this patient had looking to see what was going on. First of all, there was a barium meal done to see whether or not they could pick up any abnormality at the anastomosis, whether there was any reflux or anything like to indicate why this patient was getting sepsis. So the barium meal and follow through, well, there is a bit of radiation involved, and it's not so costly. Maybe it's $2 or $2 signs. He then went on to have a biliary nuclear medicine to see what the bile drainage was. There was no issues with bile drainage. It was draining very well. There was no hold up to this. Radiation with this nuclear medicine study was high, and the cost increases as well. He then went on to have an MRCP. Well, there's no radiation with the MRI with MR examination, and this actually demonstrated no abnormality, and you could see the actual anastomosis quite well. For some reason, then he went on to further to see if there's anything else wrong with the biliary in detail. So he had a percutaneous cholangiogram, radiation, and increasing dollar signs. He eventually came to my colleague, Dr. Tim Yusof at King's College Hospital, and there was aerobilia within the liver. And we had the MRI on the machine at that time, looking to see what was going on. Well, here's the anastomosis. This is the hepaticojejunoscopy, and the portal vein is here. So we're looking at this region here, and I draw your attention to the MVI just in this area. If you watch very carefully, you'll see as it comes through, and just ask you to be a little patient. There. Did you see that come through? That's reflux of content from the gastrojejunostomy, and you see it because it's movement. It's peristalsis squeezing the bowel content through that area into the biliary tree, causing the recurrent cholangitis. And how much did this cost? Well, there was no radiation, and it was a quarter the cost of any other procedure that you did beforehand. An excellent use of this, and an innovative use of this without exposing the patient to any radiation. Where else do we use it? Well, let me just go back. We've been using it in liver transplantation as well, and those of you who have a liver transplant program know that there are many different varieties of the way you can add a liver transplant to the patient, but the most important aspect of all of this is the anastomosis for the ultrasound examination, and you've got to be able to identify in particular whether or not there is any arterial or venous abnormalities associated with this. And what you want to do is to pick up critically on the intensive care unit a few days after the liver transplant is identification of that hepatic artery. And adding MVI to this examination, you start to pick it up a lot easier. Contrast helps you, but remember there's only a small window of opportunity to find the hepatic artery a few seconds after injection before you get contamination of all the vascular phases obscuring the hepatic artery. And this is what you see when you do a contrast enhanced ultrasound, looking particularly for that hard to find hepatic artery. And I've marked it there, and there it is. It's come through, but you see how quickly afterwards the rest of the liver fills up. So you have a very small window of opportunity just to see it in isolation. Whereas when you're using microvascular imaging, and this is the same patient, you're picking up it more clearly and you can identify it at leisure. We use it also in trauma, but I'm going to show you the spleen in trauma to just give you an idea where it's quite useful. This is a 14-year-old boy following a road traffic accident with a splenic laceration, and there appears to be some form of pseudoaneurysm there. And you can pick this up on the MVI. It shows it very, very clearly and correlates, as you can see, with the CT examination. So you're looking at exactly the same arterial phase as you would do in the CT, but without that radiation and the administration of iodinated contrast. And this is that same patient with a contrast-enhanced ultrasound examination, and it demonstrates to you that pseudoaneurysm that's forming and correlates with the MVI imaging. Again, you're looking at the arterial vascular phase here, and you see it so clearly on the MVI. But more importantly, you can use it to follow up. Here's the follow-up MVI image, and you're not seeing anything in that area as well. And you're reassured with the contrast enhanced examination that what you're truly seeing on the MVI image is in fact the pseudoaneurysm has occluded. Renal trauma, we've used it for renal trauma as well. And here you can see a devascularized upper aspect of the kidney, and you see color Doppler throughout that area. But there is something going on here, and there's something going on here on the MVI. Not sure if this is a pseudoaneurysm or not. Look at the contrast enhanced ultrasound on this patient. Just give it a second to come through, and you'll see that the contrast enhanced ultrasound is useful because it'll show you where the kidney is clearly devascularized. And if you watch very carefully, very briefly, there is a pseudoaneurysm here. But see how quickly it disappears into the parenchyma of the whole of the kidney and just vaguely shows up as an area of a possible pseudoaneurysm. But look at the MVI. There's no mistaking that that is an arterial pseudoaneurysm, and you're not losing it in the contrast as it comes through. So this is clearly a pseudoaneurysm and needs treatment, and he did get treatment. So the CT is done, and it confirms the pseudoaneurysm, but the CT image is not as beautiful as the MVI image. The angiography detects the pseudoaneurysm with very late filling, and this is successfully embolized. So and in summary now, I'm just going to summarize for you what the advantages and some of the disadvantages are. Well, advantages of MVI is it's easy to use. It's just an additional knob. It's instant. It gives you real-time vascular imaging and gives you important vascular and non-vascular information. It's another additional multiparametric technique that adds to your wonderful array of ultrasound techniques that you can use with the patient. It cannot replace contrast enhanced ultrasound, but gives information without the need for an injection. And this is very important to the operator and also to the patient. But what are the disadvantages? Well, it's much easier to use in structures such as the testes here with a very vascular tumor, because it's still movement sensitive, and sometimes the patients you're examining for the liver have difficulty in holding their breath. You just don't know whether you can use it for non-vascular movement, which I showed you with the biliary reflux, and you have no temporal information with physiology or vascularization, and in the liver you have no washout observations for malignancy. So thank you very much. I hope I gave you a nice overview of the usefulness of microvascular imaging. Thank you.
Thank you very much, Paul. It was a very nice and very interesting presentation. And maybe to the end, we'll have some question for you on chat, or I will put for you some question. And now it's my pleasure to introduce Professor Paul Novak-Kaposi from Semmelweis University, from the Department of Radiology and Oncology from Budapest, Hungary. And the topic will be about the value of elastography for staging of chronic hepatitis and the follow-up of this patient after the treatment. Please, Professor Kaposi, your presentation.
Yeah, good afternoon to everyone. First of all, I would like to congratulate you to Professor Shudu and Professor Spora for the excellent presentation they gave us today. Then I would like to share our slides with you. Dear colleagues, dear participants, let us present you our research on shear wave elastography for the diagnosis and post-treatment follow-up of chronic hepatitis C patients. Chronic hepatitis C infection is a major health concern, as it responsible for 71 million infected patients worldwide who live with chronic hepatitis. Once after the chronic hepatitis infection, if it's the hepatitis C is not treated, then there is a predictable sequence of events occurring in each patient, starting from chronic inflammation, progresses to regenerative fibrosis, and the end stage is obviously liver fibrosis in this patient, which is often associated with life-threatening complications such as hepatocellular carcinoma or portal hypertension. It's also well known that during the progression of the fibrosis, the liver stiffness is also increasing in parallel with the fibrotic changes. Conventionally, liver biopsy and histological examination has been considered the gold standard diagnostic method for liver fibrosis and also for staging liver fibrosis. There are multiple histological scoring systems have been developed during the years to report the severity of the fibrosis in these patients. Among them, the most popular ones, the ISAC score and the Metavir score. In the Metavir score system, F0 stage corresponds to a healthy, unaffected liver, and F4 stage corresponds to the end-stage liver cirrhosis. Recently, however, multiple non-invasive techniques have become available to diagnose and to measure liver fibrosis, and these techniques can replace in certain clinical scenarios invasive techniques as biopsy. Among these techniques, shear wave elastography has been well established and accepted and recommended by most of the major international medical societies for the diagnosis of liver fibrosis. Based on extensive research, results from extensive research now, we have very strong evidence in international practice guidelines that shear wave elastography is an excellent tool for initial assessment of liver fibrosis in patients with chronic hepatitis C. And we also have ample evidence to show that shear wave elastography is equivalent in its accuracy to transient elastography in the assessment of this patient. And really, these new techniques have changed the diagnostic workup of chronic hepatitis C patients. As today, if a patient is diagnosed with a hepatitis C infection, now the initial assessment of the liver status is non-invasive tests are recommended for the first as initial first tests. Among these, the elastography and serum biomarkers are recommended initially, and if there is a concordance between these tests regarding the status of the liver disease, there is no need for additional biopsy in those patients, and antiviral therapy can be initiated. And also in patients where there is an equivalent diagnosis of advanced stage liver fibrosis, in those patients also surveillance can be started for screening for hepatocellular carcinoma or complications for screening for hepatocellular carcinoma, and also for esophageal varices. In our hospital, we use the ASH shear wave application to measure 2D shear wave elastography, to perform 2D shear wave elastography measurements in our patients. For this, we use the RS-85 scanner with the CA1-7A probe, and this has proved to be an excellent setup to investigate our patient. Just to basically recap the basic principle of shear wave elastography. So whenever the liver parenchyma is vibrated from either an external mechanical force or by a focused ultrasound impulse, there are deformation waves generated in the liver tissue. These so-called shear waves propagate perpendicular to the focused impulse, and the propagation of these deformation waves can be detected with either ultrasound or MR imaging. The propagation speed of the shear waves is inversely proportional to the elasticity modulus or elastic compressibility of the tissues. This is the elasticity is determined by the Young's elasticity modulus, and it can be calculated from the propagation speed of the shear waves using a simple formula as described below. International practice guidelines also give us plentiful recommendations on the optimal scanning technique in order to ensure that the measurements are reproducible and reliable. Based on these recommendations, we have a standardized protocol for the examination of our patients. In our hospitals, the patients fast at least 4 hours before the elastography measurement. The measurement is taken from the right intercostal space with the patient lying supine, and also the arm is raised above the head. We examine on patients perform the measurements during breath hold, but not in deep inspiration. The measurement box has to be placed at least 15 millimeters below the liver capsule. In case of a 2-day shear wave elastography, as it is shown here, at least 5 measurements has to be taken according to current guidelines. In point shear wave elastography, 5 to 10 measurements are recommended. The results can be reported either in kilopascal values or in meter per secondum values, which are easily convertible with a simple formula. To guarantee the reproducibility and reliability of the measurements, there is also a very useful application in the Samsung instrument, and it's called the shear wave profile module, where each shear wave measurement is listed on a table, and here the reliable measure index for each measurement can be checked. We only use measurements which have a reliable measure index over 0.4, and this reliable measure index gives us information on the signal to noise ratio at each measurement. So measurements with a high signal to noise ratio are discarded, and also we would like to ensure that the median of the measurements which is reported, the interquartile range is less than 30, divided by the median is less than 30% in case of the kilopascal. If the kilopascal value is reported, then it should be less than 15% if the meter per secondum value is reported according to current guidelines. These are just a few examples on different patients with different severity of liver disease. On the left, we see a patient with no significant or with basically a healthy liver with no detectable fibrosis. In the middle, we see a patient with advanced F4 grade liver fibrosis. There is obvious difference both in the color map and in the measurement values between these two patients. Meanwhile, on the right, we also see a patient with decompensated portal hypertension and a large amount of ascites. And the advantage of the 2D shear wave elastography that even patients with ascites can be assessed with this technique, contrary to the transient elastography. We published our findings recently with the S shear wave system, and in accordance with the previous with the prior literature, we could also confirm that there is a very good correlation between fibrosis stage and the shear wave elasticity measured with the S shear wave application. And we, in our patient population, we could determine very high accuracy cutoff values for the different stages of fibrosis. In our patient cohort, significant fibrosis, patient with significant fibrosis had over 6.4 kilopascal elasticity, while advanced fibrosis started at 8.2 kilopascal and cirrhosis at 12 kilopascal cutoff values. We also were able to demonstrate that there is a very good correlation and inter-observer agreement between shear wave elastography and transient elastography in these patients. So basically, the two techniques are interchangeable. So recently, a group of experts in liver elastography have published a consensus statement regarding shear wave elastography evaluation of hepatitis C patients. And in the recommendation that they state that there is no need for separate cutoff values for different instrumentations as it previously has been the case. Rather, they propose a new reporting system, which they call the rule of 4, when patients are divided into 4 categories regardless of the examination technique. And patients with less than 5 kilopascal elasticity value are declared as having a normal, unaffected liver. Patient with less than 9 kilopascal elasticity are considered to be very low chance of to have a compensated advanced liver disease, while patients over 13 kilopascal are thought to have advanced chronic liver disease, namely cirrhosis, and also above 17 kilopascal, the chance of clinically significant hypertension is rapidly increasing. These authors also suggest that when a follow-up is performed on the patients, the change compared to the baseline has to be evaluated rather than the absolute value of the measurement. We have to be aware that there are also confounding conditions and diseases can also affect the stiffness of the liver parenchyma in addition to fibrosis. So, for example, in patients with acute cholestasis or very active necroinflammatory activity in the liver parenchyma, or patients with congestive right heart failure, these patients can have higher elasticity readings than somebody would expect based on just the fibrosis stage. So therefore, correlation with clinical parameters is essential for correct interpretation of the liver stiffness measurements, and also the visualization of the liver is necessary for the correct interpretation for the SV measurements. And this is also a big advantage of SV elastography compared to other elastography techniques, that also the morphology can be readily assessed on the during the elastography measurement. In our study, we also found that in patients who are obese or have breathing difficulty, and the measurement and the depth of the measurement is increased above 6 centimeters, there is a rapid exponential drop in the reliability of the measurements, of the elasticity measurements. So in this population, the examiner has to be aware that there's a high chance to end up with unreliable measurements in patients who are obese, and measurements can be only taken for a deeper layer of the deeper part of the liver. The WHO recently came up with a very ambitious goal regarding hepatitis C infection, namely that the WHO aims to eliminate hepatitis C infection as a public health threat by 2030. And they plan to achieve this ambitious goal by 90% reduction of new infections and 65% cut in the mortality rate. And the reason why the WHO was able to set this goal is that since 2014, at least in the European Union, since 2014, there are new types of antiviral medications are available. These medications are called direct-acting antiviral combinations, and they have much higher efficiency and much higher eradication rate for HCV than prior interferon-based protocols. Also, the treatment time is much shorter compared to previous protocols, and there are less side effects detected. So most of the patients now treated with direct acting antivirals are really cured for the chronic HCV infection, and this has an effect on the follow-up protocol of these patients. So this effect that basically patients who respond for antiviral treatment and after antiviral treatment there is a rapid decrease in liver stiffness is well noted in international guidelines. Still, there is a need for continuing the surveillance in patients who have been diagnosed with advanced liver fibrosis, because the risk for hepatocellular carcinoma is not eliminated, and also patients with decompensated liver cirrhosis still have to be followed for varicose bleeding. And therefore, the current guidelines recommend that patients with non-significant liver fibrosis at the baseline shouldn't be followed with imaging after sustained virological response is achieved, while patients with advanced fibrosis needs to be followed with abdominal ultrasound in every 6 months to exclude to screen for hepatocellular carcinoma. Also, with patients with fibrosis and portal hypertension need regular gastroscopy follow-ups for varicose bleeding. We also assess the efficiency of direct-acting antiviral therapy in a small patient cohort of 35 patients. Basically, all of them responded to direct-acting antivirals after chronic HCV infection, and we performed pre-treatment and post-treatment elastography follow-ups in these patients, and found that similar to other reports, the elasticity showed rapid improvement in these patients after response to after sustained virological response to antiviral treatment, and also saw that the fibrosis stage was downgraded in almost all patients in this patient cohort. These findings were in very good correlation with the other non-invasive tests of liver fibrosis, such as the FOR score, and also we found a lower risk of varices needing endoscopic treatment in this patient, in the responder group, when assessed by the Baveno guidelines. Also, the necroinflammatory enzymes return to a normal range in most of the patients after successful antiviral therapy. These results are well correspond with other publications who followed patients with transient elastography and also found rapid improvement in liver stiffness after successful therapy, and also were able to demonstrate a long-term further improvement in the liver stiffness, which can be attributed to the resolving fibrosis in these patients. So to draw a few conclusions based on these findings, a decline in liver stiffness can be seen in most of the chronic hepatitis C patients after sustained virological response, and the regression of parenchymal inflammation and the resolving fibrosis probably both contribute to rapid improvement of the SV measurements after treatment in these patients. Based on this, there is a group of experts who recommend that a new baseline measurement has to be taken after successful completion of antiviral therapy, and that new baseline should be used for further evaluation of these patients. This is a proposal and leads to further research. Therefore, at the moment, we don't have enough clinical data available to determine to what extent post-treatment, as we can change the follow-up protocol in patients with advanced stage initial fibrosis. Thank you very much for your attention, and also I would like to thank for my colleagues for the enthusiastic work and the expertise they shared us during this work. And thank you very much for your attention.